We are honored to have you join us for today's webinar where we will be discussing the future of universal health coverage in Kenya and just focusing on how best we can leverage on digital technology to improve our attainment of UHC. So a very quick introduction of who the Institute of Economic Affairs is. The Institute of Economic Affairs is a public policy think tank. We are based in Nairobi, Kenya. And what we do is we largely carry out research, and the outputs and outcomes of the research we use to engage in public policy discourses and dialogues to inform the public and, of course, the different stakeholders relating to the topics that we carry out. So this morning, we will be focusing on the health sector, like I have said, and we want to discuss the future of universal health coverage. And with us, we are privileged to have Dr. Oma Oluga. Dr. Oma Oluga is a consultant physician. He's also a health systems expert. And I know most of us will relate with him as the Secretary General Emeritus for KMPDU. So karibu sana daktari, you'll have an opportunity to introduce yourself before you start on your presentation. Quick housekeeping rules before we proceed. We will have all of us on mute. We will be managing that from our side just so that we don't have people joining and having interruptions. So as you join, don't be worried. You're on mute and your microphone and your cameras will be off, but that will change during the Q&A session where you will be unmuted and you will have an opportunity to ask your questions, if any. While at it, as the presentation will be going on, should you have any questions that you would want to air, just so that you don't forget it, please make use of the chat box. You can type in your question on the chat, and of course, Daktari will be seeing it. And during the question and answer session, I'll also be checking those, and we'll have Daktari respond, and we will have an engagement. It won't be really a Q&A, it will be more of an engagement. So that's just basically for the housekeeping. So very quickly into our conversation this morning. We have had conversations on how digital technology can be used to transform different sectors within this country. And so we thought to ourselves, well, why don't we just have a quick conversation on how we can leverage on technology to improve our attainment of universal health coverage in this country? And we know that universal health coverage was it's a concept that was introduced in 2017, but the piloting took off in 2018. And when the piloting was being conducted, it was conducted in 4 counties. We had Isiolo, Kisumu, Machakos, and Nyeri. And why these 4 counties? The 4 counties were picked largely because of high incidences of three issues. So we had high incidences of non-communicable and communicable diseases. We had high incidences of maternal mortality, and we had high incidences of road accidents. So then we wanted to see how then universal health coverage can be used to slow down the 3 issues that I have highlighted. So when UHC was introduced, again, let us remember that the whole idea was to try and ensure that every Kenyan, because health is access to health is a right, if I may say so. So the whole idea was to try and ensure that within universal health coverage, we were able to ensure better access to health services by all Kenyans, and also to ensure affordability. So as we are expanding our access, we are also expanding, but we are cognizant of the fact that by that time, and as probably is still the situation, health access to health has been very, very expensive. So universal health coverage was also trying to see how best can we reduce and ensure that access to health facilities and services is more affordable. So then came in the concept of universal health coverage. So it's been a journey for us as a country. And that is why we want to see the integration of digital technology, how it can revolutionize the healthcare delivery. And then, of course, while we're doing that, we are also ensuring that we are making the dream of achieving universal health coverage more attainable and more exciting. So why do we think that universal health coverage is something that incorporating digital technology into attaining universal health coverage is important? Because we know that some of the things or some of the factors that makes Kenya well suited for the integration of digital health into our UHC strategy is we have, for instance, high mobile penetration. We have a serious innovation ecosystem. We have seen the health sector more committed to ensuring that we have we actually attain our universal health coverage strategy. And that aside, if we look at the future of universal health coverage through digital technology, it's not a new concept because we are seeing it already happening. We've seen telemedicine and remote consultations happening. We have seen improved health information systems, and we've seen mobile health solutions coming up where we have the MT bars, we have the MyDawa apps, and all these things, if you look at them, it's just how we are incorporating digital technology in our service delivery within the health sector. So this morning, Dr. Oluga will be taking us through where we are as a country as far as universal health coverage is concerned, and also just take us through the thought process of the health as a health practitioner of why it is important for us to leverage more on digital technology within the health sector. And we would also want to understand that as a government, as a country, how well are we doing with incorporating innovation and digital technology within our health sector? And what opportunities lie within that incorporation that as Kenyans, we really, really need to consider and push and sort of try to push a bit more towards. So this morning, in a nutshell, that's the conversation we want to have. And we want to encourage you to be as open as possible so that it's not a lecture, it's more of an engagement. Because at the end of the day, you are the person who is going to receive these services. And these conversations sort of allow us to have recommendations and eye-openers towards bettering service delivery within this country. Our focus this morning being the health sector. So, Dr. Olunga, I welcome you. You have 15 to 20 minutes to make your presentation.
Thank you, Winnie, for the introduction and putting us into context about why this discussion is quite important. As you mentioned, this is more of a conversation, and I will not claim to be an expert of digital technology or even digital health, but as part of one of the voices in the healthcare system and a champion of universal health coverage, it's important that we ignite this conversation. And so I think I will take about 20 minutes or less, maybe 19, just to give us a few highlights on what we have done before, what exactly is UHC, then look into the use cases for digital technology, and then after we can go into some takeaways and question and answer or a conversation. So as you've heard, my name is Ouma Oluga. I'm a consultant physician, and I am also an advisor in health systems, design, development, capacity, and I have worked with KMPDU as Secretary General. I've also was co-chair for Health Workers for All. So I think we can now begin the conversation. So basically, UHC is a global concept, and this concept has been given prominence around 2015 when the United Nations developed it as part of a key component of the sustainable development goals, or what we call the SDGs. So UHC is one of the goals. It's goal number 3. And in goal number 3, if you look at like the components of goal number 3, then you see the promotion of well-being for countries. And the most important thing about the concept is the access to healthcare services without suffering financial hardship. And it is based on the principle of health as a fundamental human right. And this is very important, because often when we discuss UHC, people leave the concept of health as a fundamental human right, but that is exactly the basis for UHC, healthcare as a fundamental human right, because it is not that healthcare never existed before, and it is not that healthcare cannot be provided. But the difference here is that healthcare shouldn't be provided as some commodity that is for purchase, where it is willing buyer, willing seller. So this is a very important concept, because even as we look at the intersection of the several players in UHC, that healthcare must remain a fundamental human right, because that is the basis of UHC. So anytime you're discussing UHC, that is a concept that must come into play, the ability of all people to access health. Next slide. UHC generally has 4 indicators that are key in terms of uh, uh, the measurement. And these indicators are generally covering the population that is covered, the services that are offered, equity in terms of leaving no one behind, uh, and then financial protection, which is the seeking of healthcare services should not lead to poverty, as it has been the case in many jurisdictions, including ours, where people have to sell land, people have to use all that they have to seek healthcare, and sometimes with bad outcomes. And that means that many families slide more and more into poverty. And these 4 indicators of universal health coverage are the basis of the intersection between health and technology. And we will be discussing this in a number of ways, particularly how digital technology can be an enabler in assisting countries and assisting Kenya to have more people, that is more population covered, and to have a range of more services, and to have more distribution, and also to reach the marginalized and the vulnerable. Because when you're talking about equity, it is about those who, even with the normal systems of governance, there has to be an extra investment to make sure that we equalize, or we reach those that are disadvantaged, those that are marginalized. And of course, there are quite detailed content in terms of what exactly population coverage is, what exactly is equity, what exactly is financial protection. And just to mention something on financial protection is basically the fact that you do not have to use your money or out of pocket or sell property to attain healthcare. And I think these are some of, especially where technology would be very, very important, especially on the financing aspect of universal health coverage. Next slide. So one of the biggest things that happened in 2015 was basically the promotion of UHC as part of sustainable development goal, as part of sustainable development goal, and the UN giving this prominence. And so that was 2015. But UHC conversations began long time ago. UHC conversations began long time ago. You remember in 2004 already there was some conversations in many countries, and in Kenya included, as far as attainment of universality of healthcare services. But for us in Kenya, I think the first time that there was a concept of universality and equity was in the Vision 2030. Of course, Vision 2030, and then the Constitution of Kenya 2010, Article 43, that talks about everyone having the ability to attain the highest level of healthcare. And then Kenya then developed the Kenya Health Policy 2014-2030. And if you look at the Kenya Health Policy 2014-2030, it's very heavy on an attempt to provide a universal access to healthcare, and specifically on the issue of facility being at least 5 kilometers to every single citizen in the country. Then there was the Big Four agenda, which came in the 2017 election. And the Big Four agenda basically had UHC given a lot of prominence as one of the four key targets for achievement by the government. And then from the Big Four agenda, of course, UHC having been one of the key agenda of the government, we developed the Health Sector Strategic and Investment Plan 2018 to 2020, which also looked at how healthcare investments can then lead to achievement of universality, achievement of equity, and achievement of financial protection. Then, of course, the Kenya Universal Health Coverage Policy that was developed and signed 2020 to 2030, which is still in active place. So out of all of these policy documents, in a lot of programs, interventions, pilots, and I think you remember, as Winnie rightly put it, the pilot that happened in 2018 in 4 counties of Isiolo, Nyeri, Kisumu, and Machakos. Basically, Isiolo representing the pastoralist or the marginalized, Nyeri representing a place with high burden of NCDs or non-communicable diseases, as you know, issues of diabetes, hypertension. Kisumu because of the prevalence in infectious diseases, HIV, TB, malaria, and such. And then Machakos representing a peri-urban region. And so this was basically a test. And the test was on input-based UHC model. So if you're looking at UHC models, which we are not going to discuss here, there's input-based and output-based. And input-based means that there is the government puts in resources into the system. And then output-based means that the outcome of health is what is financed. So I think all of these are different models that then can be discussed in another webinar. But then before the pilot, you also remember the Linda Mama program that was started in 2013. And this Linda Mama program, in a way, as much as it was focusing on just one aspect of a service, in a way is also a test for how we can reach more populations with a bundle of services, or what we would call service coverage. So this was just maternal service, but it is also a service coverage. And if you look at the principles, it also really follows what UHC would be. And then in terms of services, again, you remember the managed equipment service. I think Institute for Economic Affairs had several talks. I've been seeing Kwame on television really engaging on mess and especially the aspects of mess that should have been made better. If you look at the challenges and the lessons, of course, the pilot gave quite a clear indication of how not to put inputs into a healthcare system that has not been optimized, and largely the biggest issues in UHC have been the clarity in the financing model. The clarity in the financing model. And when I talk about the clarity in the financing model, is that you cannot have a UHC that is confused whether it is going tax based or whether it is going input based or whether it is insurance based. I think it is very clear that we need to choose what our poison is, and then we go that direction. And so many of the interventions have been trying all this, like Linda Mama is largely tax based in terms of people pay taxes, and the taxes are advanced from the National Treasury to NHIF, and then NHIF uses what we call a fixed fee for service to sort of engage or purchase the services from providers. The second thing is that UHC is everyone's business, and therefore stakeholder management, stakeholder consultation, so that we filter all of those voices to a certain level of clarity or a certain level of agreement. And then after that, then what is very important, and this is what the WHO has always talked about, especially the Director General has been very clear about: one, financing, but more importantly, the strong political commitment, because health is as political as it can get. And from this UHC journey, then we now look at the healthcare situation, which is the next slide, in Kenya, because there has been a lot of improvement in our healthcare service delivery over the last many decades. And I think we can even attest that from the lifespan that has improved by more than 4 years in just the last decade. But still, of course, there are quite a number of gaps there are quite a number of gaps in in the healthcare system. And part of the biggest gaps that we still have is that there are population segments that still do not have health service access. And I'm talking about health service delivery infrastructure. Yes, we have built a lot of hospitals, and I think during what we call the economic stimulus program, a lot of health centers were built. And also, county governments from 2013 have really concentrated on the brick and mortar and built quite a number. But still, there are still population segments that are still lacking healthcare. In Nairobi, where I was privileged to be director health, you find, for example, the Kibra that had a population of more than 1 million people. Apart from Bagathi, there was no other public health facility. And that's why we had to create three health centers, basically level 3 health facilities. So despite the fact that there is a lot of health facilities, the distribution of those health facilities are not universal, and still there are people who do not have access to health service delivery infrastructure, basically hospitals. Then the second thing is the service scope or the service range in many of these facilities. So you find many level 2, level 3 health centers are actually empty. The beds are not utilized because people go to level 4 where they feel the services are there. And indeed, it's not just a feeling, that is where the service is. And then, of course, there's the issues of quality. I'm sure this is really the discussion that has been there, often blamed on healthcare workers, but I think the quality aspects are wider than healthcare workers. So we do not have a quality measure. We do not have a quality accreditation a matrix. Of course, Kenya from 2016 looked at what we call the Kenya Quality Model for Health, which is a policy, but in terms of a tool that can be used to measure county governments, to measure private sector, it doesn't exist. And that is part of the biggest challenges that we have in healthcare. So you find many high-level facilities adopting the Joint Commission International Accreditation for the US, some of them going for the COSASA, which is the College of Health of South Africa accreditation standards. And so this is part of the biggest problem. So you find many county governments are, not able to measure what they're actually supposed to do So and often this either backfires on the citizens who actually lose their lives, and from a perception perspective, it backfires on the healthcare workers because people peg quality on the doctor, the nurse, yet there are quality metrics, there are quality measurements that should be instituted within the system. And of course, then there are cost issues. None of the people attending this forum has not had the chance to attend an Arambe. And so we still have 67% of our population paying out of pocket. Insurance penetration in the private sector is around 2.7%. So it's, in the larger scheme of things, it is negligible as far as healthcare financing is concerned, because only if you have 2.7% of people having a private insurance, and even that private insurance is not as comprehensive. And so these are really the issues that we still have. And then there's the issue about healthcare information. So a report from one hospital is not accepted in another hospital, and therefore you have to repeat some of these tests, and that increases healthcare costs. That also makes it very difficult for communication of interventions. And so you find patients suffering harm because they have to repeat x-rays, get exposed to a number of things, yet we could have a common system of sharing this information. And related to this is basically the issue of technology. And I think this is where we stop now the discussions around health and now look at, so what should technology do to enable this health? And especially on these aspects that I have mentioned, and looking at UHC as a lever and UHC as an equalizer or a leveler for enabling optimization of this, but also using it as a leverage to achieve some of the problems that I have talked about. So let's go to the next slide, please. And the next one as well. So I think what we really need to be looking at is what role can technology play? Technology itself has been a big discussion over the years, and it has also evolved. And I think just as at a glance, technology is the single most useful tool to leverage the planning, financing, and implementation of UHC. And some of the things that I have mentioned as the situation for health, generally looking at digital financing capabilities, looking at access, and particularly right now, the issue about telehealth and virtual care, mobile health applications, again, healthcare literacy, which we will talk about in detail, remote patient care. Many of you are putting on Apple Watches, which can take your heart rate, can take blood pressure, can take your steps. And so there's quite a lot of things that we can do with technology. There are issues about robotic and artificial intelligence applications. Nowadays, we are having smart ICUs, robotic ICUs. There's a lot of surgical interventions that are nowadays done with just the guide of a human expertise, but not necessarily the physical application of the human hand. And now looking at UHC as an equalizer, because equity is a big concept, is basically process automations that I've talked about. And when you talk about process automations, it can be huge, from distribution processes, supply chain processes, information processes. It's that whole topic about process automation is as wide as the health system itself. Data sharing, visibility, interoperability, and basically the health information exchange platforms and the quality measurements that we need to have. So I think I'll just focus on three what we call newer technologies, or what I'm calling transformation, and generally the application that is in the next slide. Generally the applications of these newer technologies in UHC. And as I mentioned, this is a conversation. And so I think it's really to jog our minds into the possibilities of what we can do with technology. And the biggest, of course, there are several aspects of technology, but these three big things, like the Internet of Things, basically, that is the installation of software uh, uh, in devices. And here there are two main outcomes that we can leverage on. What we call smart healthcare facilities. In Canada now, they have a complete, one of the examples of a complete smart hospital. What we call smart hospitals here are just a chunk of computers connected. But what we really is a smart healthcare facility is where the laboratory machine communicates with the X-ray and communicates with the CT scanner and communicates with the patient watch, and so everything is interconnected, and that can allow us to have a seamless data sharing and analysis, and this is also the biggest aspect. Even if we don't look at the higher level of smart healthcare facilities, is to look at remote patient monitoring, because right now there are a number of devices that we can use to monitor patients remotely, so that they do not have to come to the hospital where we are only with them for an hour or two, or if they are unfortunate to be admitted, maybe 5 days or 3 days. Much of health happens at home. So what is this thing that we can monitor at home? And sometimes people say that they have an headache, they take medicine. When they come to the hospital, they're actually well, but you need to monitor what was going on when they were not in the hospital. And this is really where healthcare is going to make or break the improvement of health, the prevention of non-communicable diseases, and particularly the management of mental health, which is a big issue right now, the whole world. And then on the other aspect of an emerging technology, they're no longer emerging technologies, but the term that was used for them is emerging technologies, or digital transformation technologies, and artificial intelligence, which is also now changing our lives in many ways that we do not know. And part of it is basically enhancing diagnosis and treatment, again, that analysis, but more importantly, personalization. And when you're talking about personalization, this is even now being done in terms of research. And there are many pharmaceutical companies that have now jumped the queue, what I call jumped the queue, and basically used artificial intelligence to feed in some patient characteristics, so that then they don't have to take 10 years. It generally takes 10 years to develop a drug. But now with artificial intelligence, it can take 3 years, because then some patient characteristics can be personalized and already fed into the system. And this is going to lead to more affordable technologies, more affordable medicines, because you can imagine doing research for 10 years just to come up with one product, many of which actually fail. And this is why sometimes medicines are expensive. Again, optimizing healthcare resource allocation. And this is also important, because if you are a government and you can access health information of your people when they are not in the facilities, then it is very efficient to use this data to equitably access, allocate resources, and which actually then can allow equitable access interventions. Then there is the issue of blockchains. The blockchains, of course, is basically to enable transparency of health records. Again, I mentioned the issues of healthcare literacy, which is also a big component of digital health transformations and empowering patients. And then the supply chain management, drug traceability issues. 30% of all our medicines are suspected to be fake. And these are just um, uh, some studies that have been done, but we have not actually traced the medicines from the time that they are imported, whether privately or publicly, to actually follow all the patients who buy any molecule from a chemist, which now are many. Everyone has a chemist next door. So some of these things we can use technology from the time of medicine manufacturing to the time that anyone takes it, and we can follow with accuracy to ensure that we are giving people safe. And so some of these use cases I mentioned are quite a lot. But more importantly, as I mentioned, UHC financing is a big issue. And so I distilled these 4 use cases. These 4 use cases generally are supposed to just power our thinking, data-driven decision making. I've talked about that. But especially speaking about NHIF, I think now the next 3: smart contracts and payment systems, fraud detection and prevention, micropayments, in full funding. I think these are really important use cases that we can apply blockchain, we can apply artificial intelligence, we can apply technology to make sure that we are giving our patients the quality that is deserved. And I think this slide, I will just allow it to be like sort of, because there are a million use cases for application of technology, but these are just some of the 4 that I think, especially on the issues of financing, because that is where we have had the biggest challenge, especially on issues of payments, determining how much money should somebody pay, determining how much should a claim be paid, and issues of fraud that have been in the news for quite some time. This is a big application of technology. I think as I only have 2 more slides to finish, and even as I finish, I think it would be important for us to look at the Kenya case scenario. And particularly the Kenya case scenario is right now, digitization of health is one of the 4 pillars that have been identified as a lever to achieve universal health coverage. So even as Institute of Economic Affairs was looking at how can we leverage, yes, digitization is a big agenda of the government right now. I'm sure many of you have seen part of the 3 bills that are in Parliament: the Primary Healthcare Bill, the Facility Improvement Fund Bill. The other bill is digital health. And the digital health actually is very ambitious in creating a Kenya digital superhighway, in which there will be secured registries that are shared. And when we talk about secured registries, is the health workforce registry, the health facility registry, the registries that are dealing with the patients, and the registries that are dealing with other aspects of nomenclature, like the naming. And basically, what this will done is, apart from creating the digital health authority that will be administering this, is that it will create an interoperability platform where all health management information systems, or HMIs, can plug into. And these HMIs will have to be of a certain standard, speak the same language, so that if uh, a doctor has a unique identifier, that unique identifier is shared across all hospitals, so that when Dr. Luga sees a patient, whether that patient is in Turkana, when that patient comes to Nairobi, it will be clear that this patient that is identified by the system as X was seen by a Dr. Y and was given a drug that is named B. And so these are some of the very important things when it comes to technology that are really going to be a game changer in our UHC, because there will no longer be confusion about who did what when. And I think that traceability and the fact of evidence is going to be really key in terms of leveraging technology to achieve UHC. So technology has been here for quite some time. So why has it not been easy that we use it? First of all, of course, technologies uh, what can I say, as evolving as healthcare itself. So these are 2 highly evolving sectors. Healthcare is not a very uh, old profession, as so to speak. And so over the last 300 years, it has really been moving very fast. We used to say that if you read a book, you're 5 years old in terms of the knowledge you're getting. If you read an article, if you read a journal, you're 2 years old. If you read an article, you may be a year old. So that is how changing the healthcare industry has been itself, and technology itself has also been really, really changing. And so the biggest three issues, of course, is the setup costs, because you implement something and next year it is not useful. And I think we can see this with the changing iPhones. So you buy an iPhone 14, and then in 1 month they are launching an iPhone 15. So technology itself can also drive healthcare costs very high. And in places like the United States, this is part of the biggest challenges because they are very advanced in their research. So you buy a CT scan today, and then next year they have produced a new CT scan. And so because of the competition to have the latest, you find that you have to recover the cost, but at the same time you have to move ahead. And so technology itself, as much as it can be a lever to lower cost, it is also part of the problems in terms of advancing costs in healthcare, and especially this is for advanced technologies, because there are so many devices, there's so much things that needs to be done. But more importantly, people have said that healthcare, and especially the healthcare sector, has been resistant to technology. I don't think that is the correct term. I think what has been happening is that these are two different professions. So you do not expect a doctor who has been trained, or a nurse, or a clinical officer, or a lab tech, to also be quite aware of the transformative issues in digital technology. And so the digital literacy has really lagged health policy makers, leaders, and professionals around making regulatory frameworks that then can be used as leverage for UHC. But more importantly is the health literacy, because digitization only enables what has been known. It does not enable what is unknown. So you must first of all have people who are clear, number one, about the healthcare system, but number two, about the health itself, so that then this can be fed into all of these digital tools, all of these digital devices, all of these transformative softwares, to produce an outcome. In fact, they talk about right now the biggest asset in the use of artificial intelligence is judgment. So if our judgment is not right about our healthcare system, if our judgment is not right about our health, then it doesn't matter how much you apply technology to solve that problem. But technology itself is also one of the levers that can be used to accelerate health literacy. And so I think these are some of the things that we can do, especially educating patients. Now, there are a lot of virtual therapies that can be done, especially when you're looking at patient education. Many of our hospitals, like our largest hospitals that have thousands and thousands of patients who have to travel several kilometers to come for routine checkup, can have all of this done through telemedicine. And instead of investing in a lot of processes, they can actually invest in wearable devices where all of this data can be fed anonymously to the hospital, because of the issues of confidentiality and the issue that this information must be used to help the patients. So what are some of the key takeaways from this webinar? One is that UHC is based on a fundamental human right. I think it is very important for us to know that UHC concept came from the fact that health is a human right that no one should have to purchase as a commodity. Number two is that it should reach all people. And number three is the concept of essential. People uh, let me say, interchange the word essential sometimes with basic, but it is not basic. So UHC does not mean that you give lower quality services or unwanted. Essential, and this, I think if you look at the dictionary meaning of essential, means the things that you must have. And so this is really a good a way to understand UHC, the fundamental human right, the fact that you need to reach everyone, and the essential. And this essential should be acceptable. This essential should be quality. Number two is that when you're looking at UHC and technology, and I've mentioned it, digital technology only enables policies that are coherent for implementation. If your policies are not coherent, then you cannot apply technology. It will just cause chaos. And of course, you can see this in many hospitals that have very good, for example, ERPs or enterprise resource planning or HMI, then they have invested heavily. But still, you take 20 hours to be admitted or 6 hours, and the hospital say that they are fully digitized. So you cannot digitize a system that is not working. You only digitize a system that works. And the issue about political will, resources, community, stakeholder must align, because that clarity is important when you're going to be doing digital literacy and you're going to be doing health literacy. Otherwise, you get what we got during COVID-19, where there was a lot of anti-vaxxer campaigns. The three technologies that I've mentioned, which are called emerging, newer, transformative technologies, are really the game changer. The Internet of Things, blockchain technology, and artificial intelligence. And interchangeably, I think there is no limit to the applicability. And I am not an expert in that, so I think I will leave the experts in that. But the experts in technology also need to have the clarity from the healthcare system on what are the biggest problems that the healthcare system needs to solve. And then they now can apply all these technologies to craft those solutions. Kenya is moving forward in terms of its digitization. The health bill is in second reading of parliament. That means it will be law very soon. It will create the digital health authority. But more importantly, is that for the first time, we will have a government-driven conversation on what are the standards of what we call even HMIS? What are the standards of e-health? What this thing that we call telemedicine? What exactly is the standards? How can we protect the patient while enabling them using technology to have access to even services that they would rather otherwise not be having? So, what exactly is the future of UHC? I think all over the world, technology is playing a very key role, both in terms of medical technology. And when we talk about medical technology, we haven't talking about the issues of gene therapies and all of that, which actually there's also a lot of application of technology. The devices that are becoming slimmer and can now be applied even at home. Some of the healthcare devices can now be used at home because of, again, technology. But more importantly, in terms of the healthcare system, is the performance of the healthcare system, because that is where we've also had a lot of issues. So the coherence, the performance, and the ability of the healthcare system to be affordable. And I think that is where I stop my talk. I see I have taken quite a lot of time, and I want to thank you so much for being part and parcel of this webinar. Thank you, and back to you, Whitney.
Yeah, so thank you so much, Dr. Thank you for that amazing presentation and just for taking us through the journey that we have had as a country in the attainment of universal health coverage. And just from the presentation and the conversation that we've been having relating to this, it is very clear that the UHC, Universal Health Coverage for Kenya, is definitely intertwined with digital technology. And to a certain extent, our attainment of UHC is linked to how quickly we will be adopting innovations and digital technology and incorporating them into our UHC strategy. So, of course, there have been questions around data security and privacy, and you have highlighted that those are some of the challenges that we as a country have to sort of start figuring out, even as we are thinking of leveraging on digital technology to achieve UHC. And beyond that, there's also the issue with the regulatory framework. And we hope that with the Digital Health Authority being put in place and the conversation still ongoing at the National Assembly, we will be able to get to a point where we have very clear regulatory guidelines that will govern the use of digital technology, and that will also enable us to ensure the safety and ethical standards that are still maintained. And it would be interesting to get to a point where Winnie is treated at the Nairobi hospital and needs to see a doctor at the Aga Khan hospital, and she doesn't have to have to carry a whole file with her to Aga Khan. That a doctor at Aga Khan can actually have access to my medical history without having to go through such a whole a lot of bureaucracies. And while they're accessing my files, I, as a patient, I'm actually at a comfortable space that there is data security and privacy policies that have been put in place to safeguard my confidential information as the patient. So it's interesting that we acknowledge that digital technology cannot be downplayed in attaining universal health coverage. And it is also very interesting to just see that as a practitioner making this presentation, you are bringing us to the realization that it's not a conversation that is being had on the sidelines. It's really, really being had based off the things you've talked to us about. And there are policies, there are regulations that are already being put in place. And I personally am excited to see how fast it can be incorporated and the level of elevation in terms of service delivery that we can have as citizens in this country within the health sector. Agreeable, being in hospital waiting to be admitted for 3 6 hours, it's not acceptable. So yes, I agree as well that the digital incorporating digital technology is not like 100% solution to the health challenges that we are experiencing in this country, but to a certain extent, incorporating digital technology can be used to sort of address some of those challenges. So thank you so much, Dr. for that presentation. I will not try to sort of summarize it more than I already have, but I would like to, at this point, invite our participants. Should they have any questions, should they have any comments, this is your time to shine. You have the opportunity right now to raise your hand, and I will be able to see it. If you are not too comfortable raising your hand using that icon, please type it in, and Daktari will be pleased to have a conversation with you at this point. So anybody with a question or a comment, please. You can use the raise your hand icon to make a comment or ask a question. So Doc, we have a few questions from Nadia. But before we read questions from Nadia, I can see Frederick Ogilo has raised his hand. So Frederick, you could please unmute yourself and ask your questions. In the meantime, Doc, we have a few questions from Nadia on the chat box, which we will be looking at in a few. So Frederick, please unmute yourself and proceed to ask your questions kindly.
Yes, I've already unmuted. I hope you are hearing me.
Yes, we can, Frederick. Go ahead.
Yes, I will begin by thanking the presenter for his presentation. But before even we get there, this UHC has been forced down our throats. I would have wished to see those who came up with it so that we can ask them questions, given that public participation in this country has been taken for granted. But as a concerned party, I would really want to know how this UHC will work, because we've been paying for NHIF, which we just consider as tax. We get nothing out of it, nothing. I do not know actually how this UHC will work, yet we will be paying 10 times or close to that on what we used to pay for NHIF. What is so surprising is that our public participations are actually taken for granted. They are just a by the way to ensure that the powers that be succeed in what they want. But as a participant, as a person who will be paying for this UHC, I don't even know how it will work. I don't know whether it will just be another NHIF where I contribute for what is more or less like tax.
Okay, so thank you, Frederick, for your questions and your comments. Yes. So, Doc, would you want to respond?
Yeah, I mean, first, I think his concerns are largely around public participation, and I mentioned this quite clearly. And this part of maybe why we should use technology so that we can have uh, uh, acceptance, or basically our stakeholder engagement can be more effective, because I think there's some level of dissatisfaction in his questions. And what I want to say is that UHC is not about who came up with it. UHC, and I mentioned, it's based on a fundamental right that everyone should access care. Of course, there are several modalities that each country is following for themselves. And so for us, we have to have a way in which we are trying to make sure that then how can everyone have access to this fundamental human right? And so this leads to some of these policies. Like now, we are going mostly output based, and that is a pooling of finances through the NHIF. As I mentioned, private health insurance penetration is just 2.7% in this country. So in the larger scheme of things, I know that those of us that work have insurance, and sometimes you get blind that the country has insurance. It's not the case. 2.7% penetration, and this is part of also how digital technology can help to increase insurance penetration so that more people can be covered. But in our case, it's largely less than 3%. So most of the country is actually not covered. So you must have this social cover. And so I think that in my opinion is a good direction. And then, so how do we use this? And I mentioned you can assess risks, you can personalize insurance, you can, because including what he mentioned, that how much should I pay? How much you should pay is based on a risk assessment, is based on what the cost of healthcare we want should be like. And we should also use these technologies to lower the cost so that then more and more health means less and less cost. But right now we are more into the sick care where we want money so that we can pay for health services. But also related to this, I mentioned not just the digitization, there's also the primary healthcare bill. And of course, you've seen the president launching the community health promotion, the community health promoters, 100,000 people. So there's an attempt to sort of increase health literacy. There's an attempt to make sure that people are more healthy so that they don't have to come into the facilities, so that then they don't have to pay a lot of money. But I think Frederick was quite clear that he would love to have the people who designed that, but I think some of these are the attempts. I have seen Winnie, there's Dr. Alex Gitao, who is actually an expert in this field. So maybe if we can just give him 2 minutes to, I don't know whether he's listening, to just comment. I'm sure his insights would also be very important.
Dr. Alex, you could have 2 minutes to give comments before we go to Nadia's question, and I can also see another hand. Alex?
Just probably, I hope you can hear me. Good morning.
Yes, we can, Alex. Go ahead.
I'll probably just be reiterating what Dr. Lugas just talked about in terms of applying the technologies as a driver, or rather as an enabler for achieving universal health coverage. The evaluation itself of, rather the use of this importance in actually stakeholder involvement, or the stakeholder engagement in all applications of the technology itself. In terms of driving innovation, you probably be required to involve all stakeholders, because it has to be context-based. And for you to drive any technology that has to be that is going to be well implemented, then you'll probably be requiring to have a contextual assessment of the stakeholders. That is the users, that is the patients, the users themselves, who will be healthcare workers, and also talking about the patients themselves, who are also going to be using the technology, because it's a two-way journey, it's a two-way communication journey. So definitely, that's probably what I'd add on, just the difference between using technology as a driver, whether it's a driver or a facilitator, vis-a-vis being a barrier to achieving healthcare. It is actually a significant facilitator.
All right, thank you so much, Dr. Alex. So I've seen Victor has his hand up, but I would like us to proceed to respond to Nadia before we go to Victor, because Nadia had her questions. So Nadia appreciates your presentation, Dr. and she has 3 questions. The first question is what strategies are in place to train health professionals and staff in effectively utilizing these digital technologies? So that's the digital literacy that you're speaking about. So now now we are speaking from the supply side and not the demand side. And then, of course, we also have another question where she's asking, how are citizens being involved in the planning and implementation of these digital health initiatives to ensure they meet actual needs? So this you'll be responding from the demand side perspective. And then her third question is, are there plans for continuous evaluation and improvement of these digital initiatives based on user feedback and evolving technology? So long term, what's the way forward as we're incorporating it? What's the way forward? So Doc, you could respond to those three before we proceed to have Victor ask his question.
Yeah, thank you very much. I think that in terms of the strategies put in place to train healthcare workers, again, that's part of the conversation. We hope that with the prominence of the policy, especially the legislative action to have a digital health authority, that then there will be laid down procedures to sort of increase the literacy, digital literacy among health professionals. This has been the biggest barrier to adoption of technology. In the US, I think you have had these conversations about doctors complaining that they spend more time in the electronic health records rather than seeing patients. And technology itself can also be a distractor. I think you have seen with the addictions to TikToks and the addictions to social media platforms, which now beyond alcohol addiction, smoking, there's even now a branch of medicine that is dealing with addictions to social media. So that in itself is an issue. So first the literacy itself, but also the limits in terms of the applicability. And so I think that's an ongoing conversation. So no straightforward answer, but with the policy focus and with the legislative action, we believe that there will be some responsibility anchored in the Digital Health Authority to sort of continuously improve and just look at that change management. How are citizens involved in the planning? Again, I think this is a public participation, stakeholder involvement issue. But more importantly, right now is in the application of technology itself, and Gitao mentioned the acceptability and basically the involvement, is the issue of wearable devices. I think the whole of healthcare is based on consent. And so even before you look at public participation, which Frederick had asked about, the, the whole of healthcare interventions is premised on consent, and consent is verbal consent and written consent. Many of the procedures that are invasive are written consent. Many of the treatments that are not invasive are verbal consent, but there has to be verbal consent. And this also looks at your third question about evaluations, improvements, feedback. Now, just recently, we celebrated what we call the World Patient Safety Day. And when you're looking at can really improve is patient feedback. So one of the core 5 components of patient safety, a big component of it is involvement of the patient in the decision making. Yeah. Involvement of the patient in decision making and improves itself. But more importantly, then this can be used to improve decision making, but not just decision making, also to improve the interventions. So I think that is my insights on the 3 questions that have been asked by Nadia, and it is part of the whole conversation of the changing landscape. It's not a one size fits all. So you can't say that this is really what's going to happen. Technology is evolving, healthcare is evolving, and both of those sectors are evolving quite rapidly. And so I think there has to be continuous involvement, continuous engagement, continuous learning, and certainly continuous measurements of what exactly is of value to the person, because at the end of the day, healthcare is supposed to improve health. And when we talk about health, it is about your ability to make a living, your ability to have quality, your ability to be productive for yourself and the society. Yeah.
Thank you, Doc, for responding to Nadia. I hope, Nadia, your questions have been satisfactorily responded to. So, Victor, you have the chance to ask your questions to Daktari. And Doc, I know you have another engagement by 10:30, so I will request that as you will be responding to Victor, you can also give your closing remarks, and then I'll do the closing, and then we can release you. So, Victor, please ask your question.
Yeah, thank you very much. And thank you, Dr. Omologa, for the great presentations and insight on the digital technology in achieving universal health coverage. My name is Victor, as been said, and I think the topic of universal health coverage is quite important topic. And sometimes I think that we pay more attention to finance protection than the other pillars of universal coverage that we talked about, the population being covered, the quality of care. Yeah, and in regards to the population, you mentioned about health literacy as an important aspect. And I'm thrilled by the current talks on digital technology, which talked about the Internet of Things, artificial intelligence, and blockchains. And with regards to that, I'm just worried because I was just trying to look, our current literacy level is about 82%. And that's just basic ability to read and write. And I think recent reports show that internet users in Kenya is about 40% of the people are internet users. And now we're talking about advanced technologies like AI in health. I just wondering what measures are we putting in place to actually improve health literacy, to improve internet penetration, and make people be more accessible to this knowledge and also understand this knowledge, so that as we expect, as we talk about digital technology and transformation in health technology, we're able to reach the masses and are able to understand about. Thank you.
Thank you, Victor. Doc, as you'll be responding to Victor, please add to Mayaka's question, which has been posted on the chat box. She appreciates that we are actually now having these conversations on leveraging on technology to enhance medical care, and what I think he would want to understand is if there is a way that treatment can be standardized. This is based off an experience that she has that the participant has had in terms of a misdiagnosis. So she would want to understand if there is a way treatment can be standardized moving forward. So you can respond to those two, and then with your closing remarks, kindly.
Thank you, Victor, for your question around the 40% people using internet. I think Kenya is quite advanced when it comes to penetration of mobile technology, internet, and even the use of internet. So maybe I think it's just the use of internet for health is what may be low, but the use of internet generally as a country is quite high. I think we rank among one of the highest countries in the world. And the other thing that is good for Kenya is that our adoption of technology is also pretty fast. This is why you see many of the world's technology companies are coming to test here in Kenya. Of course, some of them fail, but Kenya is also quite a fertile ground for testing, especially in the world of financing or peer-to-peer financing. I wanted to talk about that a bit. You've seen a lot of loan things; those are called peer-to-peer financing. And then that already shows the penetration of internet literacy itself. But the internet literacy for health is what is an issue. One, because of the trust that people do. So I think there has to be building of trust, and that is why the regulation is very important, a framework, so that then you're not just giving your data to people that then can steal your identity, that then can use that information for purposes of not improving your health. And I think that the regulatory framework will have to sort out. And as the regulatory framework is sorted out, then there will be more confidence for the use of internet for healthcare purposes. issue about standardization of care, I mentioned that this is where we have really lagged behind. I mentioned many of our hospitals now doing accreditation from institutions that are based abroad, because we need to have a quality accreditation standard. And I think there is a thought around also instituting quality standards, which can then be uniform, which can then also ensure that you are sure that when Dr. Luga sees you, that the information they give you and the interventions that you get are the same as when another doctor sees you. And so this is really part of what technology can help with. In terms of professional standards, and not just professional standards, but also healthcare standards, generally facility standards. Right now, we have a number of facilities that shouldn't even be called health facilities, because people go and they open some things that resemble, I don't know what they are, and then they call them health facilities. And so I think the whole issue about standardization, quality, accreditation, that is part of how we should use technology to make sure that we have visibility. And it is very clear, because then you can disseminate protocols, you can, and especially, I think for Zephania, what we mentioned here is the identity of the health worker, the identity of the drug you've been given, the identity of the facility, in terms of these shared registries that the government is now creating. So if it is a facility X, we know it's a facility X whose identity is this, and in that facility X is Dr. Luga, whose identity is this, and in that facility, the medicines that you were given was identity Y. And so we can trace that and sort of put a standard across it. But this is work in progress, and I think as we talk about digitization, these are some of the gains that we hope will be realized with time. So I want to thank you so much, Winnie, for this webinar, and for inviting me to make this presentation. And certainly, of course, can be reached on other discussions around healthcare systems, design, development, capacity of healthcare systems, and certainly around universal health coverage, so that then we can gain more coherence, and we can be on the same page as far as some of participation in some of the stakeholder engagements that I'm sure many people also lack. That part of the issues, and I want to go back to Frederick's question, even as I summarize, part of the problems that we have had in the health sector generally is that even if today the government told you that, okay, now give us your views on the NHIF bill, there are very few people who are literate enough, of course, to sort of analyze it objectively, to say that, okay, my health risk is this, and I am not able to pay this because I anticipate that maybe I am socially protected or this. So I think some of these kind of webinars are very important in terms of improving our capacity to participate and to give feedback in some of these engagements that we are often called by county governments, by national governments, by civil society, and by private sector, and to really empower ourselves to engage and to make decisions that we participate in. And so for me, I look at it as a key input in improving our capacity as a country, and especially as professionals, to be able to give evidence-based participation in areas that we are required to give our input. And so thank you so much. And with those many remarks, I beg to close it.
Yeah, so thank you so much. On behalf of the Institute of Economic Affairs, I would also like to take this opportunity to thank you, Dr. for making time to share your insights on the direction we are taking with incorporating digital technologies into our health sector, and just to ensure that we are leveraging on digital technology to attain universal health coverage.